Can you hear me? Dr. Junaid, can you hear me?
Assalamu alaikum, everyone. I'm actually Junaid Kalia. I'm one of the neurologists, neurocritical care, neurointensivist, and epilepsy specialist. My special interest is in machine learning in medicine and neurology. Today, I'm going to present the overall idea behind what machine learning in medicine is. It's going to be a quick overview. Those who are interested in actually going into more detail, I have a series of 5 lectures that is all posted on YouTube through my website. It's called AINeuroCare.com. That's my personal portfolio on slash Junaid Kalia. Otherwise, you can see all my lectures on it. It goes into prelude, which actually is more about American physicians, and then all the further 4 lectures is for anyone who's interested in machine learning, in neurology, and in medicine particularly. So here are the 5 lectures. As you can see, they're all posted on YouTube if you are actually interested in going into depth on any one of them. Uh, the only important points in the prelude was basically that we as human beings overall overestimate the technology. And that basically means that you can see that machine learning and artificial intelligence is all over the news by, um, self-driving cars. It's going to achieve the moon, for example, and we overestimate it in the short run. But unfortunately, what we do is we actually underestimate the power of that technology in the long run. And that's exactly what's happening. As a matter of fact, we are really turning the curve right now, and people are calling it that machine learning and artificial intelligence is just actually a hype. But as I will go through this, that how massive impact it will have, not just in healthcare, but every other industry as we can think of. Um, so that's called Amara's law, and that's actually if you go through all the technologies from cell phones to internet to self-driving cars, we have gone through this overestimation, and then believe it or not, we actually underestimate these technologies and their impacts. From purely US perspective, we have seen that what we believe is that electronic health records have basically the bane of our existence because we want to take care of patients and not basically be clerics, workers of maintaining records. And that has been the biggest issue for us. Anyways, this machine learning, since we have been collecting data for about 10 years now on electronic records and have basically not made any sense of it because we have not been able to drive wisdom from all that data that has been generated, this seems to be the perfect time when we will be able to drive wisdom from all these data that we have collected for years. Another big thing is that there's a movement sort of going on in US that doctors should organize. And the biggest thing we should organize is for that healthcare data ownership. Who owns my data? Who owns my body's data? Should belong to the patient, should belong to the person. And it doesn't mean only the electronic health records in the sense of what medications I am, what problem list I have hypertension or diabetes. Is it going to change the way I'm going to be employed in the future or how my insurance rates are going to change? But even as simple as my Apple Watch data, my Fitbit data, this all data should belong to, legally speaking, to me. And that's where the biggest concern is. A European market from GPDR, which is basically the data have made significant strides to actually make sure that that data belong to the patients. Unfortunately, US is lagging significantly behind this movement. However, let's really go into what the major issues are. So we're going to go through overview, technical basics, principles, and then go into challenges and limitations. Please feel free to put in your questions on the chat window, And what I'm going to do is eventually I'm going to come into it and answer them through that, or at the end, I'm going to answer them all the way together. So let's just give you the overview of what machine learning is and what AI is. The word that is defined, the one word that would define this perfectly is disruptive technology. What that basically means is that any technology that is going to change the way we do things in a particular way, or is going to transform the way we do things, is classified as disruptive technology. And AI basically remains to be in the middle of it. This is just one slide to make you understand that how the world has changed. From 2008 to backwards, if you see, the most valuable thing in the world, if you look at stock prices of anything, is actually oil. And oil was the biggest thing. Now the most valuable resource in the world is no longer oil, but it's data. And you can see all these major companies that are on the top 5 of the stock market are actually the ones who actually own the data. So as far as the disruptive technologies of tomorrow, the biggest things that we talk about is robotics, biotechnology, Internet of Things, decentralized consensus, which is basically part of the blockchain technology, and autonomous vehicles. If you see all of it, in the middle of it is artificial intelligence, which is basically machine learning. And we use that synonymously, but I'm going to come to the difference between them. But at the end of the day, the one thing that actually stays in between them, the one is the enabler of all the other disruptive technologies, including genomic sequences, is machine learning and artificial intelligence. And I'm going to come to it why, but that's the key thing. There's none of these technologies will actually exist, to be honest with you, if there is no artificial intelligence in the middle of it powering all of it. Now, this is a very important graph. If you look through this, this is what we call now coming to a fourth industrial revolution. The first one was the steam engine. Massive impact in productivity back in 1800s. We went from horses to basically steam engines. And though that steam engine actually changed the way we transported, and therefore it took to railways. And now we actually had the second one that's coming from telephone, automobile, and the biggest one was electricity. Electricity transformed everything around us because we were spinning wheels to turn out yarn. And then come 1980s, and we saw the insurgence of computers followed by the internet. And after this, now we're seeing a dip and a change. And then as you can see, the first one was going to come up will be the artificial intelligence. Then we're going to see battery storage and energy storage, robotics, genomic sequences, and biotechnology, blockchain technology. And this is going to be the complete disruption of the economy as we know it through these 5 technologies: artificial intelligence, robotics, genomic sequences, and biotechnology. As I said, all of them depend on AI/machine learning to be valid in the sort of feasibility perspective. This is the most important quote of, if anything you learn from this lecture, you should know this quote. This is given by New, who was the Stanford AI lab previous head. Now he has changed, he has moved into a different career. And then he said, even the metaphor of electricity do not do justice to artificial intelligence. Internet. Internet was communication between, and there are 2 billion people around the world without internet access, except for their mini cell phones. So electricity, the way it transforms industry after industry, AI will do the same. So very powerful example, and that's what we want to get into today, that how this is going to change, and this is also going to change healthcare as we know it. Interesting fact from Aristotle: as long as there's a hand needed to spin the yarn, slavery will exist. This was a quote from Aristotle, and now we know that slavery is gone, and one of the major contributing factor is electricity. And this is because that electricity brought amount of productivity, increase in productivity per person, that is, you don't need slavery anymore. And that's what's exactly going to happen with ML and AI. As a matter of fact, people are more worried about it than increased time, because there's increased productivity. What are humans going to do? And that's kind of the discussion point from futurist perspective, that how we're going to use our time if we don't have enough to work for. So that level of productivity is expected to come by one person because of the help of ML and AI. Now we move to the technical basics. As I said, I have all of this in a massive, like all of these lectures that I'm talking to you about is 30, 35 minutes each. So you can always go back and refer to the big lecture of total of 2.5 hour series. But what I wanted to cover here is basically the most important points of all the different lectures that I gave. So let's move on to the technical basics. In this, I will define how ML is actually works and how it will impact machine learning is going to impact healthcare in particular. The whole paradigm of medicine as we know it used to be that, you know what, I'm looking at the patients, I look at four, 5 of them, and I saw that, for all stroke patients, hypertension is actually the one that is prevalent. So I create a hypothesis and I say, you know what, hypertension is the most important risk factor for stroke. That is in a hypothesis. I do it observational studies, and then I do a clinical trial to confirm that. This is the classic deduction method that we have always used. Machine learning flips the whole theory around. What it does is that we give a massive amount of data and throw it in the machine. And what it does is that it actually produces its own observations and then creates some patterns into it. And through those patterns, then when I look at it, it highlights the patterns. Then I create multiple hypotheses. And through those hypotheses, I can test theories after theories if I want to. And this just completely flips the whole way that we used to do medicine clinical trials on its own head, because now I don't have to go back and create a hypothesis and go all the way to confirmation. As a matter of fact, I have continuous data flowing in, and then I'm creating more and more observations, patterns, and I can create more and more hypotheses and test them through the whole database. So there is a deduction way which we used to work, and then it's completely flipped now, and then this is more of an induction pattern recognition way of doing and achieving things. Machine learning mainly is divided into supervised and unsupervised. It is the word machine learning clearly defined. So let me just define it again. I'm sorry, I didn't put that slide in. The big circle is artificial intelligence. In that, there's a small circle called machine learning, and in that, there's a small circle called deep learning. Artificial intelligence is designed to mimic human intelligence. Machine learning is defined as a computer that knows how to basically compute itself, is programming itself. So any program that is designed in a way that it can program itself is by definition machine learning. The term learning in it is the key thing. Anything that can improve on itself. If I have written a code and if it doesn't consider that it can improve on itself, then that does then only it is considered machine learning. Otherwise, it could be just old plain statistics like we used to do Bayesian statistics. We use naive Bayes, mean, median, mode, whatever, simple statistics. All of them are basically been done. The differential between them is that the machine can learn through more and more data and actually increase its accuracy over time. So let's learn into what are the this whole slide is actually one of the very important slides. So classical machine learning that we think about is supervised learning. What is that? Supervised learning is that if I have 100% of data, I actually train the data on 80%. And this is all labeled data. For example, there's 1 million images of cats and dogs, and I actually take 800,000 images and I actually label them for them that this is a cat and this is a dog, and this is called supervision. So I supervise the computer to actually know what is a cat and what is a dog. And then another 5% will be actually my confirmation. So I will just take all that computer labeled data that I've told the computer, this is what this is what this is. And then the computer tests itself, and then on the rest of the 15% of the data, 80% was training data, 5% was validation data, and then another 15% would be test data, which I would actually test if the algorithm actually works. This is what we used to do classic machine learning. It was very popular from 2001 to basically 2015. Then we moved on to unsupervised learning, and unsupervised learning is basically decreasing the amount of labeled data that I had to give to the computer. It went from all the way from 80% to around 15% or so that I would just label. So rather than labeling from 800,000 images from 1 million images, I'm just going to label 100,000 or 150,000 images of dogs and cats. And then same thing, 5% would be validation data, and another 80% would be test data. They both have their benefits, and when we are trying to apply different kinds of machine learning on different kinds of data, we use them. Classically speaking, when there's clustering, like for example, dogs, cats, wolves, etc., unsupervised learning is good enough. When we have to make associations like apples and oranges are fruits, similarly, unsupervised learning is great. But when you're looking at regression analysis, when you actually have to deep look into prediction analytics, more label data is better because it will increase the accuracy. Well, of course, scientists thought of something that, the biggest issue with the cost is that, labeling of cost of labeling the data is significant. There are many ways people are doing it. If you're interested, there is a good video, again, on my big lectures that I've shared. It's called From the Verge. We all have been labeling data for free for everyone. And Amazon has an Amazon trunk service, which actually pays you cents to label data. And there are people, millions of people in Africa, India, Bangladesh, Pakistan, who are labeling data and making decent amount of money. But they came up with semi-supervised learning. And the idea was that not completely unsupervised and not fully supervised, but somewhere in the middle. And the whole idea behind was to decrease the cost of labeling. Now another big one is the reinforcement learning over here. This is by far the most impactful kind of machine learning that has been developed. What it does is that it creates an environment, and in that environment, the computer is set to give some basic rules. Okay, you can do X, you cannot do Y, you can do Z, and you cannot do D, whatever that environment is. And then if they achieve the goal that we wanted, they get +1, and if they don't achieve the goal that we want, they will get -1, and that is it. And then the machine is left to its whims, and then eventually, from sequentially decision making, it will come to a paradigm that actually creates the most amount of rewards. And this literally does not require any labeling. This actually does not require any cost. And this is, to be honest with you, the most transformative way of machine learning. And this is where the biggest fuss is. As a matter of fact, when I told you about that, machine learning, artificial intelligence, machine learning, and then deep learning, and then inside the deep learning is the reinforcement learning. So this is the most sort of hot topic right now that we're looking at as far as doing deep and machine learning. The next big one that we talk more about medicine is natural language processing. The most common form is Siri, Alexa, Amazon, Google Assistant. And these are going to now be applied to look at all your records. So for example, when I see a patient, I generate an electronic health record, and that record actually it has to be read by a human being. With this natural language processing, we basically teach the computer how to read and write and actually listen. So they can now look at all the electronic records and then produce natural language processing to create wisdom through them. So if I'm looking at stroke and the cardiologist is saying AFib, the computer can automatically know that there should be a connection. And if there's no connection made, then it can prompt, hey, Dr. Kalia, by the way, do you know if the cardiologist actually told this patient 2 years ago that they might actually have atrial fibrillation? So these kind of things that were in the background are going to come. The wisdom is going to come through all the data that we have collected for years, and the computer can actually read through them and then produce connections that I can miss or anyone can miss. So natural language processing is basically the key. The other thing is that they're putting actually Alexa, Google Assistant, etc., in patients' rooms, and again that is to produce faster ambience of intelligence in the room. They're putting in cameras. Again, the idea is to see what the patient is saying, moving, etc., to create safer rooms. So these are all going on. These are experiments that are going on in Mayo Clinic, Cleveland Clinic, etc. The next big one is machine vision. Clearly, teaching computer how to see. The biggest application that we see in radiology, and this would be the first, radiology is the first subspecialty of medicine that is going to be completely transformed by machine learning within the next 2 to 5 years. It's not too far. It's not 20 years from now. It is actually, we're thinking about change. This change is coming soon enough that there are less and less radiology residents applying for radiology residencies right now because they know that the whole field is going to be changed and there will not be enough residents needed in US. This is ongoing as we speak. Again, now active and passive learning. So of all of these, we can apply if it's actively going to be learned or is it going to be passive learned. So passive learning is simple. We did the data, we labeled the data, and then passive learning model, and then the output. The difference between when you have actually data that is semi-labeled and then we have put it in the active learning model, it keeps going. I mean, is it a cat? Is it a dog? Or I don't know. If the computer says I don't know, if the confidence interval of that particular image to be cat or dog falls at 0.5, that is 50-50, then the computer is going to spit it out and say, you know what, I don't know what this is. And then it's going to ask the human to label that particular data, and then it's going to go into the system again, and then this is going to improve. And this, again, active learning model can actually decrease the cost of learning and labeling. And then, of course, this is going to continue to improve the accuracy of the generated models. It can be applied to any of the last models that I just spoke about. And this is the one that I was talking about. I don't know if you remember this, Capace, which is actually now a Google company. Initially, it used to do handwriting analysis, and now it has changed to vehicle input. And basically, we're training for free for Google to identify cars as we help Google to basically learn handwriting. So as you can see, we are supervised learning for free on the web, as you may have seen everywhere, multiple websites. This reCAPTCHA. This is actually the one that I've been talking to you about. So if you have a minute, go ahead and look at that video. And this is another big thing. The issue with unsupervised learning is that and then when you actually combine it with reinforcement learning, is that you can literally create virtual environments. And as a matter of fact, if you look at the Google record, Waymo actually did 10 billion virtual miles, and they keep creating more and more environments virtually for the car to actually navigate through. And especially those kind of tricks where the car is actually on the right turn and you have to actually see the passenger move, those kind of things are going to be significantly different, and therefore they can create specific environments to train uncommon environments that they do not encounter so much, and that actually makes the drive more safe. However, this is actually extremely problematic, and that's where when I was talking about advocacy and how physicians should be more mindful is this. The semi-supervised learning and unsupervised, literally unsupervised, like clearly, there is no supervision, there's no label, there's nothing. You just literally give the data to the machine and say, figure it out for me. And not only that, you can actually augment the data from a different machine learning. So let's say you have only 2,000 pictures of cats and dogs. You give it to another computer, which is also machine learning, and say, you know what, make 1,000,000 out of them. So they can actually, now we have ways to actually augment the data. And that is a big issue, because what if companies are doing it with MRIs and CAT scans? This is not a real data, and then they're spitting out these problems. So this particular semi-supervised and unsupervised data augmentation is especially scary. And when we are looking at these things, at least people, when I'm talking to vendors, when I'm talking to CMOs of the hospitals, which particular software that we have to buy for the hospital, these are the things that we ask the vendors to provide, because if they have used this, then we basically disqualify them, at least at my institute. But again, these are the things that are going to be much more scarier in the context of Pakistan, because there's less regulation. Even in US, there's no regulation. Don't get me wrong. We're not even there. The regulation over here is really terrible at this point in time, because FDA has no idea how to prove it. It just came out with some guidelines. But again, there's at least some sort of institution that is upheld. In Pakistan, it becomes much more scarier, because a lot of this can happen. And that's one of the reasons I wanted to come out with this sort of lecture series, is because if you are looking at these, you have to ask the right question to the vendors. Another fantastic deep reinforcement learning that I was just talking to you about. If you have the minute, go ahead and look at the YouTube video. Let me see if it can do that. Um, if you go over here, we are actually looking at attempts 30,000, attempts 200,000. So the car is actually learning just reward and not basis. This is nothing. They have just given us, given them an environment and a reward and a positive. And then if you can see how many attempts it has done is 300,000 attempts to actually learn how to park. They just they just literally create an environment, produce an agent, and gave him the reward. And then it can automatically generate an action, and then it generates multiple actions, 300,000 actions, and then finds the best way automatically. This level that you don't have to do anything. You just literally design few parameters and let the computer figure it out is what the big issue is. And this is extremely powerful because it takes a lot less human input and the computer learns by itself by experimenting over 1,000,000 times if need be. These are other two big examples. As a matter of fact, if you look at this emergent tool used for multi-agent interaction, again, these are important because I'm going to come and tell you some of these medical applications in a minute of these, all of them. It is just mind-blowing how machine learning is going to change, even not in a single agent, but into a multi-agent environment. Fascinating. As I said, the biggest application of machine learning in medicine would be computer vision. Keep talking about cats and dogs. So the way the neural networks is designed, and again, if you can think about the neural networks in the whole big talk, is basically what you do is you have an original image, you change it into parameter-based images, and these are different types. Over here, we just see a grayscale. It cuts it out on what we call feature extraction. So it extracts all the features of the particular image, and then they have multiple layers, which we call convolutional neural networks. So it goes from A, B, C, D, all of these, and then in the first one would be the hair color, the second would be the eye color, the third would be the fur density, the fifth would be, I don't know, style of sitting. And then eventually when it goes through multiple convolutional network layers, then it identifies that particular image as a cat. As you can see over here, they're pointing out the fur portions again. Each feature is actually going through multiple layers as well. So no matter what you do, at the end of the day, my eye can look at the whole image and say as a cat, but if you go through this particular image density that it goes through is just mind-boggling. And as a matter of fact, it's sometimes that's where the computer actually fails sometimes, is it just forgets to see the forest through the trees. So, however, this particular friend is much important for computers, for our medical imaging. So this is your classic MRI, which in my opinion is showing a tumor. And then as you can see, what it does is that literally it takes segment by segment, takes it out and blows it out into convolutional layers. And each layer is actually marked by, is it normal, is it abnormal, or if it is abnormal, is it a tumor, is it a ischemic stroke, or is it a bleed? After going through the convolutional layer, it can go through this ReLU layer, which is basically a pooling of layers in this particular study that was done, medical deep learning application in medical imaging analysis. This is open access. So if you don't have library access, you can actually download this paper anyways. It goes into a pooling layer, and then again, it goes through connected layer. So idea is that, of course, we have seen a one single image, and this is actually a 1 pixel. Looks very big on this image, but at the end of the day, it's literally a pixel. And then all these pixels are then combined to see one pixel right next to the other. So that's called connected layers. And then finally, the output is given to either is it a tumor or not a tumor. We don't have one working software right now for tumor detection, but I have one functioning automated detection of acute ischemic stroke right now at my institute. I can pull it up actually. It's called Viz AI. There's a tutorial on my website as well that how it actually not only detects acute acute ischemic stroke. It detects if there's a large vessel occlusion, and if it is, what is the level of large vessel occlusion, and what would be the change of CT perfusion at that point in time. Fantastic app right now using machine learning in real life as we know it. And that actually, to be honest with you, outperforms neuroradiologists, and we have done studies to confirm that. Decreases, and it takes about, if I were to look at the images, all of them, etc., it takes me about 7 minutes or so. It spits out a result in 7 seconds. So again, as I said, it's not just about it. Every 5 minutes, if you let the stroke patient go, you can lose a limb. So time matters, and that's the clarity of this. As I'm saying, productivity increases significantly. Now I have one less thing to think about. I mean, clearly, another big thing is when it doesn't know, it just lets you know, I don't know. Fantastic. So you can actually yourself pull up the source images and look through them. So the productivity is going to increase, as I told you, and I don't know, 10 years from now, is another medical students even need to know how to read medical images anymore. Anyways, it's a different time we live in. So when you look at the whole basis of computer vision, the biggest one was actually in 2014 GoogleNet, which is also called ImageNet. And then they were actually good at classification, again, dog versus cat. And then what we actually move to the next step is basically detection. What basically it means is that if it is a cat, is it a Persian cat, or if it is a dog, is it a pug, or is it a golden retriever? And then it's the furthest step came was segmentation. Segmentation would blow your mind away, because what it is able to do is not only let I can say that this is a bleed in the brain, that is detection. What it can do is it can literally point out exactly the area where the bleed is, and it can automatically calculate the volume of bleeding for me, which is extremely important. We use ICH volume, intracerebral hemorrhage volume, all the time, and then I can create the ICH score. Again, it takes a lot of time to measure it and then calculate it, which is automatically spits out within seconds. I'm not going to go into a lot about super resolution. I didn't even go into my own big lectures as well. Um, the first thing is, to be honest with you, I don't really know this much myself. And then secondly, this is mainly used more so in enhancement of the image. The resolution is superiorized and then eventually turned down to actually see the difference. And then, of course, NLP is natural language processing, and it's clearly when the dense net was announced by, again, Google, then there was attention and fast text. These all are done separately. I'm using Google a lot, but as a matter of fact, believe it or not, Microsoft is way ahead of Google, especially when medical machine learning is concerned. Here's a classic computer vision, basic mammography. You can see that this is a normal breast tissue, and you can see that the density of the breast tissue is normal. And then over here, you can see that there is classically saying that, okay, this is malignant. This is the word detection. Now, not only that it detects it, it actually segments it out. What is the portion of that particular radiological image that is actually malignant? Benefits are significant. As I told you, the mass size, the mass volume, the mass density, and if I have a computer generated biopsy that I'm going to take, it will be much easier for me to target that tissue. As a matter of fact, I might not even have to touch tomorrow. I would rather have an Xbox controller and click this point, and it will go and get a biopsy for me. Not Again, not too much far into the future. These are real things we are experimenting with. This particular technology I'm talking about is now being tested right now in Germany. However, in US, we are doing telestenting. So telestenting is basically the cardiologist sitting 10,000 miles away, and then it sneaks up the whole catheter all the way to the heart and can put in a stent completely remotely. This is not, again, not future. We are implementing it at one of the institutes over here as well. So doing a tele biopsy is much easier than putting in a stent. This is the key area, at least when I use in my outpatient therapies, that I can see that how this is implemented. And this is now where, so first was segmentation, And then now the segmentation is actually differentiating between what is the volume of the ventricles. And not only today, uh, there's a small change that can happen over time that my eye can never predict, or my eye can never see the difference, the slight differences. As a matter of fact, people have studied the ventricular volume, and when they looked through the time, the volume was actually slightly increased, and they could predict who's going to become, who would be affected by Alzheimer's disease early, or who's not going to be affected by Alzheimer's disease by just having a temporal relationship between scans over time and seeing the ventricular volume. Similarly, again, we have applied this in our other neurodegenerative disorders, and we can automatically segment out the difference between midbrain, pons, and medulla, and we're able to see all this. Again, these examples are from neurology because I'm a neurologist. That doesn't mean that there are not any good examples from cardiology. As a matter of fact, there are fantastic examples in cardiology, oncology, etc. Since I am a neurologist, I've picked up all the examples from neurology. And as you can see, this is a classic beak appearance. And then we suspect that if this is degeneration, there's a chance that the multiple sclerosis would be higher on the differential diagnosis. Again, this actually just tells you that, this is machine segmented, this is manually segmented. And as you can see, sometimes machine segmented actually picks up a little better than manual segmentation. Either way, if this pulls me up when I'm looking at the patient, it just makes my diagnosis, my intuition much faster. And it's not like anything is hiding. If it's not correctly done, I can easily pick it up when I'm talking or when I'm looking at those images. Next, we come to natural language processing. How much time have I left with? Hello?
Sorry, yeah, about 10 minutes.
So, fair enough. So natural language processing, again, I was telling you about that, how we have collected a lot of data here in US, UK, etc., when we have gone through electronic medical records. All this data can actually, again, go through the similar steps of segmentation, detection, synaptic analysis, and semantic analysis. And then all this data can actually produce wisdom for us. And they have applied it to multiple areas. And these, literally, if you look at this code, this is mind-blowing because SVM, special vector machine learning can easily be applied by 20 lines of code. I'm going to show you an example in a minute. Same thing with NLP. It's not just that, you can pick it up that, a radiologist dictated the report or whatever, and then if you see that it shows that, okay, this patient has pneumothorax, it can easily detect critical findings, and the radiologist doesn't have to pick up the phone and then call someone that this is a critical finding. The computer in the background can just pick it up by catching that phrase and then communicate it on their behalf. Again, improves productivity significantly, let alone now, of course, GE. If you go to my website, there's another big table that shows FDA approved machine learning and AI approved, FDA approved, like they're available in the market to go. You can buy these softwares right now, and about 43 of them have been approved. And you can use these to detect pneumothorax and, of course, early identification of critical findings on chest radiology, as I can show you. The big thing is, again, this is going to be a fantastic tool that is Project Empower MD. This is from Microsoft. Again, these are going to be available. So the patient is actually interacting with the physician. And while the physician is speaking, as you can see, it automatically creates a whole note for them. And once the note is built, this is all done over natural language processing, it can fill in your history of presenting illness, review of systems, etc. And all of it can be done automatically, again, saving a lot of time, especially here in the US. Okay, now we come to principles. The 6 principles that I came up with is just not my invention. People have talked about it, but I'm going to go very briefly on it. Again, this is a whole brand complete lecture. The term we use is not going to be computer-made diagnosis. It's going to be computer-aided diagnosis. So we're not replacing physicians. We're just replacing, we're We are aiding the physician to come up to the diagnosis, detection, etc. Constant improvement is the key thing. If they're not going to improve, it's not machine learning by definition. Real-time feedback is going to change the way I practice because it is going to decrease the latency of my decision making. It took me 7 minutes to review images. Now it's going to take me 7 seconds. Huge difference. Streamlined workflow. Again, I look at the large vessel occlusion and I have to pick up the phone, find who's on call, the neurointerventionalist, and then the person is going to be contacted. By the time he picks up the phone, everything can be streamlined because, again, this artificial network can actually connect and make things much easier. However, the biggest problem will be accountability. In US, of course, here everything is at this point in time behind how the best word to call it. They actually know all the algorithms. I have no idea to check them. I have no idea how to reproduce them. I have no idea how to do meta-analysis. I have no idea how to actually confirm what they're saying is true. So that's a big issue, that how machine learning should be accountable. That's what we have been struggling with. And then lastly, accountability in the sense of true, who's going to be liable in court. Again, those things that we have to think about, that, who's going to be sued? Is it going to be GE sued because it said it's a pneumothorax, or is it going to be me because I said yes to the reading of machine learning? Again, these are things that we have to work through. And then, of course, it should be dependable. It's not something that, that the accuracy changes because somebody misspelled a code. And things can change. The last and the big one is, again, challenges and limitations. There's data and algorithmic related, and I talked about it. The big one is data ownership. We should all believe that this data belongs to us. I mean, I can sell it. I don't mind. And I think that should be okay. There should be a marketplace to sell my data. That's not a big deal. But as long as, there is a clear defined data ownership. Other thing is that, when the data is collected, it's properly collected, because there could be a lot of noise in the data, and a significant loss in the data. We should collect all the data we can. And then lastly, as I talked to you about, that proprietorship, those paywalls, GE, Google, they're not actually sharing with me how they're going to come up with this particular diagnosis. And this is going to be a big issue, the proprietorship nature of the algorithms. And then lastly, can I explain them? Because how the hell did they arrive with that conclusion? Again, I talk about this whole in a full 40-minute video. Interestingly enough, there's only one state in US that actually says that data belongs to the patients. Believe it or not, the rest of all the states do have no legislation, or the purple have a legislation that actually says either the doctors own it or the healthcare record company owns their record. So it's annoying to see here in US that we are that backward thinking. Again, we need to organize. These are the characteristics of big data. So these slides are available. I think I did send out a PDF beforehand. So if nobody got it, you can request it from Daniel. Then, of course, there's legal and regulatory related challenges, that if who's accountable for harm, whose responsibility is at the end of the day. If machine learning spits out that Junaid Kalia's genetic code suggests that he's going to have, I don't know, colon cancer, is his medical insurance coverage going to go up? Because that's quite possible. Prior authorization is not something you deal with. And again, when FDA approval considered, because it does reflect a lot on the whole world, that there should be stricter guidelines. One more slide that you guys can actually go into, that let me just go over here. So if AI is accurate and correct, and I follow it and the outcome is good, no injury, no liability. But if I reject it, again, at the end of the day, I can reject it because I think that AI was inaccurate, and then the outcome is bad, then whose injury and liability is it? Is it mine because I was wrong, or is it AI accuracy because it was correct? But again, is it FDA approved? So we are literally living in times that we don't know who's going to be liable, and then we have to come up with a symbiotic relationship between machine learning and physicians making decisions together. And again, this is not far-fetched. I'm telling you that I use a machine learning software every day for stroke care at my practice as we speak. And lastly, of course, empathy and then doctor-patient relationship is going to change as well, because um, what are you going to answer to the patient if he's going to ask, how did you come up with the diagnosis? You're going to just pull up an app on the phone and say, okay, this because it told me so. So again, those are things that we have to consider. And then eventually, if machine learning is widespread and it's applied everywhere, uh, there's going to be a decreased empathy. So those are challenges that we see in the future. One fantastic example, because people sometimes don't know this. So this was actually a software called Sidious. This was a computer-assisted personalized sedation system. It was a computer program that was attached to a fentanyl bottle and a propofol bottle. And then those people who are going through colonoscopy, they could just push a button and then the computer would take care of the sedation. It wildly actually was inaccurate. It ended up giving massive doses. People were near intubation. Then they had to pull this whole system out from the market, which was done on machine learning. Again, these are the kind of issues we come up with here in the US, and then this was exported clearly that this shouldn't have been the case before going through proper trials. So when I'm talking about this, challenges and limitations, when actual lives matter, and we have to be careful before implementing these kind of systems. Again, this was implemented in 2015, taken off the market in 2016, and an computer-assisted sedation system. And the last thing is that with all these technologies that I just talked about, and one of the things that I didn't talk about was Internet of Things. That's another lecture that's going to be coming up on my website, is with the advancement of small internet devices like blood pressure machines, pulse oximetries, simple things that we know that we use all the time, and that's what hospital is made of, right? At the end of the day, if you really think about it, the hospital is for monitoring, because treatment can be delivered half the time at home. With all these, with the prevalence of internet, advent of 5G, and now artificial intelligence that can actually notify me if there's going to be a challenge coming, that there will be less and less need of hospitals. And then the shift in care is going to change towards basically when we say acute care, which is 15%, is all hospitals, is going to go down to 5%. Digital care, which includes telemedicine, telestroke, teleneurology. As a matter of fact, a group of Pakistani physicians here in North America are going to start telemedicine in, I think, in Aptabad or something, which I will be part of, is because, you can, like 8 p.m. to 12 p.m., it's actually 8 a.m. to 12 a.m. in the morning over there. We can actually see, 10, 20 patients over video. So things are going to change significantly. And again, with artificial embedding me, that brings in the confidence, at least a little bit of more confidence, that I'll be notified of big events beforehand. I haven't gone into that. There's a whole big topic about, I'm a critical care physician as well. So you can actually, I can detect hypotension, sepsis causing hypotension up to 15 minutes earlier than anything I can predict otherwise, which is a huge difference. We sometimes just take 5-10 minutes to get medications out of the epinephrine, out of the norepinephrine, to get to the patient, so Primate, etc. So huge difference. And some of these examples that I haven't shared are mind-boggling to actually see them. Again, these are in practice as we speak. That particular system is installed in my neuro ICU that detects hypotension and due to sepsis event up to 10 minutes early. And I generally get a decent warning about 5 minutes, which is good enough when the patient is in the ICU. So those of you who are interested can follow me around on the website, email me for feedback, and subscribe to my YouTube channel if you want to. Again, these are all the different slides that I have talked to you about that have already been completed as far as lectures is concerned, and these are coming. So acute ischemic stroke, direct applications I was just talking about. For example, segmentation and e-aspects. As you can see, there's a detection, how we're going to detect and segment it out. If you're looking at disease prognosis and prediction, over here it can see predict hemorrhagic transformation. as far as evolution in chronic disorders, it can actually also predict what kind of clot it is from very early signs. Same thing with cerebral hemorrhage. It can actually see where the interparenchymal hemorrhage is. Not only it can see interparenchymal hemorrhage, it can actually see where the TBI is. It can see where the subdural hematoma is, where the extradural blood collection is. It can also detect critical findings and etc., and then automatically calculate ICH volume. So all these are different lectures that are coming. Some of them are recorded, some of them are not recorded, but everything is available on slides for now. Most of it is actually recorded. So I'm gonna stop right now, and we're gonna go back, and then I'm gonna leave some time for questions